Thank you for the opportunity to present, and I'm also a first-time visitor to your country and have enjoyed it tremendously. My presentation today is going to actually bring a little bit of data to the discussion, to begin discussing a little bit about an emerging role of pharmacists that are practicing clinically. You might not have heard of transitions of care, but I want to spend a little bit of time, because we've got both pharmacists and learners in here, talking about how do we utilize these individuals not only to advance practice opportunities for pharmacists, but as importantly to provide good opportunities for learners to practice their skills of being future clinical pharmacists. So the last two speakers talked about snow. I'm going to share a little bit about our organization, which we don't have much of the snow, but the University of North Carolina, where I practice, is an 800-bed institution. As you can see, it's laid out in a very broad 4 buildings there, and fortunately for us, it's across the street from the School of Pharmacy, so we have a very tight relationship between the medical center as well as the School of Pharmacy. And so our medical center, we have about 350 FTEs, or about 400 individuals that work there. And if you notice sort of the breakdown, we've got about half of them are pharmacists, and about half of them are pharmacy technicians. So we are utilizing pharmacy technicians a lot more in our country, recognizing there's many distributional or technical functions that those individuals can provide. And we also have a very large pharmacy residency program this current year with 35 pharmacy residents, and so we're very active in training and promoting the growth of pharmacy residents, because we know that that is a venue to clinical practice in the hospital setting. Now, as we talk about the journey of the patient, we've really tried to structure pharmacists throughout the care continuum process. And what I mean by that is, when a patient enters the hospital setting, we want to be there all the way through when that patient leaves the institution and transitions to their next care setting. And so there's multiple steps in that process, starting by when they come into the institution. We want to make sure that we have an accurate medication history. It's really hard to provide care to a patient if you don't know what medications they're taking. And then as that patient works through the process, when they go home, it's very important for us to make sure the patient knows what medications they're taking. And as they transition to home, as they are in that setting, we also want to make sure that we engage with them. Those steps in that process, those transitions, is what I'll talk a little bit here in a minute about transitions of care. But to be able to talk through all those steps, we have a variety of different pharmacists that work there. That spans all the way from what we call central specialists, individuals that are specialized in compounding, in the distribution of medications, all the way to clinical generalists, those you could refer to as your pharmacotherapy specialists, to your clinical specialists, individuals that have a very unique body of knowledge for certain disease states, certain drug classes. And those individuals make up the acute care, or some people refer to that as the inpatient setting. Complementary to them, we also have ambulatory care pharmacists, as well as pharmacists that work in the retail or the community pharmacy setting. All that falls under the umbrella of the hospital or health system setting. And so if you remember what Dr. DePiro was talking about earlier this morning, the demarcation between what's a hospital and what's a community is very gray or fuzzy right now, in the setting that the hospitals or health systems are getting much more into the ambulatory care setting than what they maybe did 10, 15 years ago. And so there is a much more cohesiveness over practice settings. So that's how we practice in the hospital setting. But the other thing I sort of want to talk in here, because most people here are academia, is that if we're going to advance clinical pharmacy, it's incredibly important to have tight relationships between academia and the practice setting. So I showed that there were, in the picture of our hospital and school to begin with, they are physically located next to each other. They are across the street. Yet even though we were across the street from each other, about 10 years ago, we didn't work very closely. And so we recognized that it was an opportunity that we needed to begin engaging much closer with us, because in the hospital setting, we had practitioners who were excellent in what they did. And we could utilize them in the curriculum to help teach clinical pharmacy. And at the same time, our students that were in the schools of pharmacy needed to have experiential education, and so we wanted to form those relationships. And so we created something that we called the Partnership in Patient Care. In essence, we are partnering together to improve patient care. And we did that, and we called it One Pharmacy Community. It didn't really matter who paid your salary. It didn't really matter who you worked for. At the end of the day, the roles of pharmacists are to make patients better, to improve their quality of their health care, making sure that medications are used appropriately. Academia is striving toward that, as well as practice settings. And so if we could bring together, we could actually accomplish a lot more than what we would be able to accomplish together. And so that created a focus in our organization that led to something called the layered learning practice model. And this is a point that was very instrumental for our organization to realize that students, as well as residents, weren't only there to learn, they were there to give. And what I mean by that is they were there to give patient care, and through providing patient care, one would be able to learn much more practicing than they ever could learn in a textbook setting. And this idea of the layered learning practice model mimics the medical model. Dr. Maddox was talking about the medical model a little bit earlier when he was talking about team-based care, but I think everybody recognized there's an attending physician, there's many times medical residents, and then there's medical students. Well, the same idea here is we have an attending pharmacist who is pretty much your clinical specialist, your highly trained individual, working alongside a pharmacy resident, along with a pharmacy student. When we started talking about this model, most people felt like pharmacy students and educating pharmacy students in the hospital setting took away from their daily activities of patient care. People were happy to precept students, but they also recognized that it took a lot of time and it added to the workload of what they were doing normally. When we started talking about the concept of the layered learning, the idea behind it was, how do you begin utilizing these individuals into your organization such that they will allow you to do much more? They can allow you to extend the care of your patients. And when you start bundling all those together and began recognizing the opportunity, it opened up a tremendous amount of opportunities for organizations. So if you'll see on the right side of this slide, we have these individuals called transitions of care specialists. Not only was it important for us to ensure that patients got the right medications when they're in the hospital setting, but most inpatient stays in the United States are about 5 days. We push a lot of activities within those 5 days, and when those patients transition to the home setting, we want to ensure that that is safe for multiple reasons. And so we began talking about how do we begin utilizing pharmacy students and pharmacy residents, pharmacy extenders into the transitions of care activities, such that that whole continuum of care I showed you earlier, that in each of those steps we would be able to provide pharmacy resources so that a patient's full journey would always have a pharmacist or a pharmacy department employee alongside of them throughout the course of the time. And so that led to this concept of how do we begin employing individuals to work within transitions of care. And so transitions of care, just to sort of reiterate, because I know this is a new concept here, is that it's a movement of patients from one setting of care, many times the hospital setting, going to another setting of care, many times that is the home. Now, why is that important? Well, what we've recognized in our elderly in the United States is that 1 in 5 patients are readmitted to the hospital within 30 days. So if an elderly patient has been admitted to the hospital, there's a 20% chance that they will come back to the hospital in 30 days. And the reason why they're coming back is because we've not done a good job in their care. Why are they happening? Well, we don't have good communication from inpatient providers to outpatient providers. So either notes are not documented, physicians or other providers don't look at those notes, or there's not a good communication about what is the plan of care for this patient. We also recognize that 2/3 of all those events that led to readmissions are medication related. Well, who are the medication experts? It's we as pharmacists. And so pharmacists can play a large role in reducing the readmission if those readmissions are primarily medication related. Part of that is because patients don't know what their medication needs are or what their goals of therapy are. 28% of patients can't name their medications that they're going home on. 1/3 of patients that don't even know why they're taking those medications, and others are experiencing adverse effects. So we asked the question, what does it look like, and what would be the activities for a pharmacist and others to provide care in that transition? And so ACCP, Dr. Maddox's organizations, has done some very thoughtful work around that. And what they've demonstrated is that the challenges that we have is there's poor communication. When a patient leaves the hospital, there really isn't good infrastructure because you're relying upon patient care members to take care of that. There's not good medication information. And unfortunately, the communication between hospital pharmacies and community pharmacies many times don't exist. And so when a patient shows up to that pharmacy with their prescriptions, they don't know what they should be taking, what they should be providing them. And so we recognize there's a large role for pharmacy in transitions of care. So we started looking at the data. What data demonstrated out there to show that the pharmacist's role was in the care setting? And most of the information was on the inpatient setting, demonstrating that if a pharmacist on the inpatient setting was involved in the care process, you had a better chance of reducing overall readmissions. So because of our partnership in patient care, because of that connection between the school of pharmacy and the medical center, we decided how can we bring learners, pharmacy students, pharmacy residents, as well as clinical pharmacists into the setting of transitions of care to be able to see could we impact overall readmissions. And so the first thing is we began utilizing pharmacy students as well as pharmacy technicians to take medication histories. What a great opportunity for individuals to sit down and interview patients and ask them, what medications are you on? Why do you take them? How often do you take them? Do you have any problems with that? Many times during that interview, not only you recognize that patients don't know as much about their medications as they should, but you begin finding out about medication-related problems. You know, every time I take this medication, I have this strange effect. Or I've been noticing recently that I have tingling in my feet, or I get dizzy when I stand up. Well, in my pharmacy school training, we were always talked about first-think drugs. So what kind of medications could that patient be taking that could lead to that effect? And so during that interview process, you can gain a lot of knowledge about the patient. But we also recognize that was a tremendous opportunity for pharmacy students. By going through that, by learning how to talk to patients, they're not scared to talk to them. But they can also begin investigating, thinking, understanding. Oh, they learn about something, or they saw something they didn't learn, so they go back and learn about it in medication. They read that Dr. Maddox was talking about. So that spurs into a lot of information. But we also made sure that pharmacists had roles in that. There's a concept called medication reconciliation. That's taking about what the admission medication history said, what did the physician start the patient on, and reconciling those two. Many times through that review, you understand, wow, that patient was on that blood pressure medication, but the physician didn't start it. Well, maybe they should be on that medication. Or differently, they had one dose of a medication, but the physician started on another dose. Was that intentional, or was that a mistake? Begin talking through that, understanding what happens there. Same happens at the discharge. Ensuring that when that discharge instructions are written, that the appropriate medications are on that list. In addition, are there medications that were stopped when they admitted? Should they be started when that patient is discharged? Great role for pharmacists to take an ownership in the patient's medication list. In addition to that, we created a standardized medication checklist for inpatients. That at each patient that was at a high risk for readmission, we wanted to make sure that the pharmacist completed this transition checklist so that we could ensure that all of our patients had the most appropriate therapy to minimize them getting readmitted. And after about 1,700 patients, we began looking at the impact of that inpatient checklist. And you'll notice that there are two statistically significant reasons for reducing readmissions. One of which is, did the pharmacist be involved in the bundle of activities that I just described, medication reconciliation, admission med histories, and discharge counseling, and follow-up. And so the most significant predictor of reduced readmissions is ensuring that that patient has a follow-up visit with a provider once they leave that hospital. And if we could do that reliably and consistently, we could actually reduce readmissions. So we began asking ourselves, could a pharmacist be the person that saw that patient at that readmission visit? Now, many times we think, well, the clinic is the domain of the physician. They see patients, they schedule visits. But what we had as an issue was we had limited access. There was only so many clinic appointments, and so they might be discharged from the hospital, but we couldn't get that visit for 6 weeks out because all schedules were booked. But if we put a pharmacist in there and said that pharmacist would be able to see that patient, and we could see that patient quicker, could that have an impact on scheduling of visits as well as reducing readmissions? And so we brought the pharmacist in there, and we actually started scheduling visits. And so a social worker and a pharmacist would see the patient, and then they would meet with the primary care provider to provide out the plan of care. And what our goal was is within 14 days, we would schedule that visit. Ideally, it would be 7 days, but that wasn't always deemed possible. And so what we started doing was connecting our inpatient clinical pharmacist with our outpatient pharmacist, you can notice on the right, so that we would have direct communication between those two to ensure that if warfarin or Coumadin was managed on the inpatient setting, or insulin, or antihypertensives, that plan would be communicated to the pharmacist in the clinic so that they would know what they were wanting to do, and that pharmacist in the clinic would be able to continue that dialogue through that. And so we would be using pharmacists together to minimize transitions of care. Just like we had on the inpatient setting, we created an outpatient transition checklist so that we could ensure that consistently the same amount of information was being documented, that there was a consistency of care, that we could document each time that pharmacists were taking care of. And not only were we seeing the patient, but we were also actually giving We were calling them after 72 hours after discharge. We were calling them after the visit so that we could have dialogue with them to ensure that they were doing well and not getting readmitted to the hospital setting. So what was the data that demonstrated that pharmacists in the clinic could work? Well, the first thing that the pharmacist did, part of that checklist, is that they would always review their records and get knowledgeable of the patient. They would want to understand, why were they in the clinic setting? What are some actually issues associated with that patient? What are some of the medications they're on, so that I can begin talking to that patient? We also had a thorough medication review and education. We sat down with the patient. We actually talked to them about their medications. We ensured that they knew what they were taking. Great opportunity for pharmacy residents, great opportunity here for pharmacy students in addition to clinical pharmacists. And it was interesting. Here are some of the major interventions that we found when we were talking to the patients. 50% of the patients had issues with non-adherence, meaning they were not taking their medications. Well, I think we all recognize that if patients are not taking their medications, bad outcomes many times will happen. And so we spent a lot of time just talking to them about why they should be taking their medications or adjusting their therapy that from